Hello, everybody, and welcome to this SciTalk brought to you by SCI. SCI aims to speed the transition of research out of the laboratory and into industry for the benefit of society. One of the ways that this can be achieved, and a charitable aim of the society, is to deliver lectures like these and help our diverse audience understand more about how science can help us lead better lives, improve our societies, and deliver economic growth. If we go to the next slide, please. Before I introduce today's speaker, a quick word about the format. So you have all been muted, your microphones have been muted so that we can better hear the speaker. But we do want to hear from you, and if you have any questions, please add them to the chat of this meeting, and I will put them to our speaker at the end of the talk on your behalf. So my name is John McFarlane. I am Director of Publishing at SCI. SCI began publishing scientific reports, notes on industrial developments and trade reports shortly after it was founded, and in 1882. So I'm very proud to continue a tradition that's been going for 142 years. SCI publishes 8, very soon to be 9 research journals covering subjects as diverse as food and agriculture and energy, science and engineering. We also publish a magazine called Chemistry and Industry and a range of digital and social media channels. So if you're interested in science and innovation, its application in the scientific industries and how it impacts society, I would urge you to visit these publications, which can be accessed via the Society's website, but not until you've heard today's talk. So today's talk is the first in a series of 3 that will focus on dementia. Dementia is a complicated syndrome associated with ongoing decline of brain function, not just memory, but also language understanding, judgment, mood, and movement. Currently, 1 in 11 people over the age of 65 in the UK are living with dementia, and it's estimated that 1 million people will have dementia in the UK by 2030. As populations age across the world, the numbers of people with dementia will rise globally. But as we will learn over the course of these 3 talks, dementia is not only associated with aging populations. There are different types and causes of dementia, and researching the disease in its many forms will help us understand the syndrome, lead to better prevention and treatments, and gives a better understanding of brain health. So if you can have the next slide, please. Our very distinguished speaker this afternoon is Professor James Rowe. Professor Rowe is a neuroscientist and cognitive neurologist. He serves as director of the Cambridge Centre for Frontotemporal Dementia. He leads the dementia theme for the NIHR's Biomedical Research Centre in Cambridge, and he is chief scientific advisor to Alzheimer's Research UK. Professor Rowe trained at Cambridge, Oxford and UCL before working as a neurologist in London and Copenhagen. He runs a large research team, which is very active in studying dementia and has published many research papers. But he is also an active clinician at specialist clinics and the Cambridge Memory Centre. He's very much focused, in his own words, in treating the symptoms of dementia and making the brains of patients work better. So straddling the clinical and research, the clinic and the research laboratory, he's very well placed to talk to us today about where we are with our understanding of dementia and where we are going. So welcome, Professor Rowe. Thank you very much for speaking today, and over to you.
Thank you very much for your kind words in the introduction. I'm going to just move to share my slides, and hopefully you can see my slides there. Is that with dementia written up?
Yes, we can.
Very good, thank you. So I just to hide, I've no disclosures or conflicts of interest that are relevant to what I'll be talking about today. But first, we should just reflect that how common dementia is. I think many of the people listening in will have had dementia in their families or close circle of friends. The lifetime risk is 1 in 3 of us. So 1 in 3 of us will be destined for dementia unless anything's done. And the other way to look at that is that even before COVID, even during COVID and since COVID, it's the #1 cause of death in the UK. And I'll just flesh that out with some other numbers to put on that. So that in the UK at the moment, there's around 800,000 people living with dementia of different sorts. You can double that if we include people with mild prodromal forms of the illness, and you can double again if we look forward 25 years to the year 2050. So it's a major problem. It currently costs the UK somewhere in the region of £35 billion a year to manage, both direct and indirect costs. And if you wanted to bring a treatment to market, you need deep pockets with estimates somewhere around the £1 billion mark, particularly for Alzheimer's disease or a relatively frequent dementia like that. So the scale is eye-watering. But we often come across it in other ways. I like to keep up with the literature and always keep an eye on the newspaper headlines. So we hear a lot of positive news stories too, whether it's curry, chocolate or coffee will help cure our dementias. There's some things that aren't so good, that it might run in the family, that sleeping tablets, or even sugar can make it worse. And then lots of promises around the cure and the diagnostic check. So hopefully I'll try and take you through some of the reality checks on these claims, think about where we are and where we're going in terms of dementia research and towards the cure. So I suppose the first question is just to reflect on what dementia is and what it isn't. We use the word dementia as an umbrella term, but actually encompasses a very, very long list of individual illnesses. I've shown up here the common 4 illnesses, so Alzheimer's disease, which usually leads the way with memory, but can affect vision and language and other problems. Dementia with Lewy bodies, closely related to a form of dementia one can get as one lives for some years with Parkinson's disease, bringing a mixture of movement problems, cognitive problems, difficulty in vision and memory as well, and fluctuating vascular dementia, so the damage from strokes or mini strokes building up, often giving problems in terms of apathy or very slowness of thinking, as well as memory problems, and frontotemporal dementia, changing personality and language. So they all change these types of cognitive functions and movement and balance, also changing other aspects of our bodily health, around mood and sleeping and the sort of internal body clock. Now, these different dementias have different causes and different treatments and different treatments. I'm actually going to skip over their differences and focus much more on what they all have in common. And yeah, so they have an awful lot in common. One of the things is that they are illnesses that unfold over the lifespan. There's been a tendency for the last 100 years to focus on the late stages of dementia. So that when we've lost the ability for our brain to work, for language, memory, and attention so much that we're quite disabled, unable to manage everyday life. In fact, the dementia word refers now to that loss of daily function. But before that comes quite a long period for many people of what we call mild cognitive impairment, where life is close to normal, but there are troubling and annoying symptoms, epitomized by not being confident where we've left our car in the car park, or losing the thread in conversations or around appointments. But one is pretty independent still. And this might seem the earliest stages of symptoms, and might be the earliest stage at which one reaches a memory clinic. But the illness itself has been happening for many years before that. We can see in people who have a genetic predisposition to dementia, we can show that there's shrinkage and there's changes in the brain 15, 20 years before even those first symptoms appear. And even before that, the connections between the nerve cells that start to get affected may be even 10 years before the atrophy begins. So we've got a very, very long set of biochemical processes, beginning even perhaps in childhood or early adulthood, with this slow, very slow accumulation of what I'm going to call junk proteins. These proteins have different forms, different names. We hear a lot now of amyloid, there's tau, and there are other proteins. Proteins that in a normal state and healthy state are very orderly and well behaved, but rather like that sort of claggy cooked spaghetti, it loses its order, becomes sticky and problematic, and it can become problematic in the brain cells, damages those connections, leads to cell death and shrinkage, that in turn leads to memory impairment. And only very, very late in this lifespan of processes does it cause the functional disability we know as dementia. This sort of schema over many, many years of disease process is common to all of those dementias, and it has some implications. If we think about the way we treat it, until very recently, treatments have all been focused on this very late stage, trying to mitigate the symptoms, providing supportive care, financial and legal help, and so on. There's, over the last 10 years, increasing interest in trying to bring people forward and engage with and deal with these milder symptoms where independent life continues and everything's there to preserve. One of the challenges here is that with these very mild early impairments, perhaps only half will go on to a dementia in a small number of years, and half won't. So there's been a lot of emphasis on what we call biomarkers, tests that will tell us perhaps about the state of play or the prognosis of someone with mild cognitive impairment. Because the way we might treat it, the way we would research it, and the way we would make changes in our own life if it's affecting us would be very different if you knew one was on a rapid trajectory towards dementia in a small number of years, or alternatively, as is the case for some people, you're going to be annoyed by grumbling symptoms, but essentially more the same over 10, 15, 20 years. Those trajectories will be very, very different between two individuals. But I do stress that even this early stage of the illness in terms of symptoms is really quite late on in the process of the biological processes. So research is switching more and more to thinking about prevention and treating those root causes, the aggregation and stickiness of these proteins like amyloid and tau, trying to stop them sticking, stop them gumming up in the cells, get them to be cleared out of the brain early, and to reduce the impact they have on inflammation in the brain, cell death, and the breakdown of those connections. So many of the new treatments are targeting these early stages. And once we recognize that the dementia biology really unfolds over a lifespan, it changes how we think about what treatments we might use at different stages of the illness. And I've just sort of put here in the coloured ovoid some sort of general strategies as to how we might treat or prevent dementias, targeting those proteins of amyloid and tau, reducing the effects of inflammation or loss of synapses, trying to help later on the nerves cope with the stresses caused by these proteins, and then trying to recover cognition or relieve late symptoms. These approaches, very broad brush strategic approaches to the disease, will vary at different points in the lifespan. Now, in case you think these varieties of treatment are just pie in the sky, the good news is there is an awful lot of drugs coming through into treatment. So this little sort of target plot shows drugs that are in largely in phase 3 and 2, and some of those in phase 1 for treating Alzheimer's disease. There's about 150 that are being tested. And this really just shows the energy and the sense of possibility. Not all of these will work, clearly, but some will break through. Some will move from phase 1 to 2 to phase 3 and then succeed. One of the interesting questions we face is it seems unlikely that they'll work uniformly. There'll be some patients or some people with dementia will respond better than others. So a lot of the effort that's going on at the moment is thinking ahead, trying to get the framework and these biomarkers correctly thought through, so we might get the right treatment to the right patient and at the right stage of their illness, rather than assuming that one medication will suit everybody. And part of that is around the developing of the right tools, the right tests in blood or brain scans, for example, to know if a drug is working. It's surprisingly difficult to show if a new drug is being effective on a timescale that's realistic and a timescale that's affordable. So a lot of the emphasis now that's accelerating drug development is getting those tools right to let us know that a drug is one to back and to take further, and it looks promising. Something else to highlight amongst those 150 trials of different chemicals is just how varied they are. We've heard a lot this year about anti-amyloid treatments, and they're down at the bottom here, that there are further anti-amyloid treatments trying to get perhaps more effective ones that work in slightly different ways targeting amyloid, but they're actually quite a small minority. There's a lot of interest targeting inflammation and immunity in the brain that seems to put petrol on the flames of dementia once it starts, trying to help neurotransmitters work to recover function, helping the synapses, these connections, be resilient to the disease. So, and other targets here. So there's incredible diversity of targets, and that's another thing we should be very grateful for, that I think this increases the likelihood of breakthroughs, that we're not just backing one horse in this race. And the research does get results. So after many, many years of the amyloid hypothesis, trying to push and treat amyloid and remove it, and many false starts, this paper came out last year, a drug called lecanemab. And after about 18 months or so of a really very careful inspection of its safety and efficacy, this received its approval for use in the UK. It means it's provisionally licensed to be given. Doctors can, in principle, prescribe it. The challenge being, though, is it's very expensive. And at the initial price that it was being proposed to, it was seen by the National Institute of Care and Excellence and NICE, it was seen to be too expensive for the benefits that it brought. So we're going to see, I think, a period of further discussions around whether it might be possible to deliver this at a cost that would be acceptable and feasible in NHS. As it is in several other European countries, North America, I think Japan, Korea, and China now. So it's gaining traction, but it is expensive, and that needs to be borne in mind. As I said, research gets results that some of these tablets are medications, are not all tablet form, they're different medications in different forms, are beginning to break through. And it's a numbers game, essentially. It takes a lot of effort. You need plausibility, you need success at phase 1 to take to phase 2, success at phase 2 to take to phase 3. And at each step more forwards, the costs escalate and the stakes get higher, but without guarantee of further success. So there's a very high attrition rate. But with 150 sort of horses in this race, we can be confident that several will make it through. But although 150 medications sounds promising, this is tiny. If I were to tell you that last year alone, in the cancer field, there were 6,500 trials. So when I come back to saying it's a numbers game, the more we invest, the more we commit to dementia, the more we do in terms of those clinical trials and smarter clinical trials, the more success we'll have, just as our colleagues in the cancer field have had over the last 30 years. It's transformed the expectations of doctors and patients with cancer, not just a question of how we manage it, but or even is it treatable, but which treatment do I get, and have you got the right type of treatment for my type of cancer? This is now the discussion we have in the cancer world because of this relentless and tireless effort leading to many trials. And the 150 trials for dementias is encouraging, but we just need to push harder and faster. It's also worth thinking about prevention. Rather than just shutting the stable door after the horse has bolted, we think about prevention. And this is also, I think, the understanding of the role of prevention has moved forward immensely in the last 3 or 4 years. The Lancet set up an international commission around dementia. And essentially they said, what are the risk factors that seem to increase someone's risk of developing a dementia? Is that risk factor something that's in principle treatable with current knowledge? And if we were to treat it, how big an effect it would be? And if we put these factors together, we can start to get some estimate on what proportion of dementias might be preventable. And this is the net result. This has been recently revised with the net result that almost half of dementias could in principle be preventable by tackling these risk factors. And it's a very interesting list. Different types of approach needed at different points of the lifespan. Some steps are really in the realm of policymakers. So education in early life, for example, you see it at the top here or down below, air pollution. There's very little we can do as individuals to reduce the pollution in the air around us. This needs national policies and governmental policies. We need somewhere in the world of healthcare. So hearing loss, look, actually the single biggest modifiable risk factor would be hearing loss, midlife hearing loss. I think it's a travesty in the UK. People have to pay in many parts of the country for hearing assessments, for hearing aids, for what is the biggest modifiable risk factor for the biggest cause of death. This should be seen as part of healthcare, just as blood pressure care might be through healthcare. Managing cholesterol is seen as part of healthcare and managing diabetes. So healthcare provision could make major inroads if we got this right, with long-term impact on the numbers of people with dementia. Actually, to be encouraging, I haven't put the graph in for this, but it's worth reminding ourselves that although the total number of people with dementia in the UK is rising rapidly, age for age, the risk of dementia has dropped very markedly over the last 25 years. And very, very nice epidemiological studies systematically looking at the population risks of dementia. And if you're now 75, the risks of a 75-year-old these days having dementia is about 25% less than a 75-year-old risk of dementia in the early 90s. So we've come on a long way, and that risk is there also, reducing risk. If you're an 85-year-old, your current risk is less than the risk of an 85-year-old would have been in the 1990s. But this improvement is completely overwhelmed by the successful aspects of our aging population, that people are living longer, and that swamps the age for age reduction. So getting healthcare right is important here. Aspects of lifestyle, things that we can do, not drinking excessively, managing diet, not smoking, either managing our diabetes or through weight and exercise, reducing the risk of diabetes, taking steps to minimize brain injury, whether that's in sport or cycle helmets or whatever. So healthcare, lifestyle, and some societal issues. Something that's also come to the fore in the last few years is around social isolation and the importance of social isolation for putting us individually at risk. So collectively, if we took all these steps through policy, healthcare, lifestyle choices, and societal aspects, we could have a huge impact on the burden of dementia nationally. I want to come on to the role of biomarkers. We hear a lot about biomarkers. Biomarkers are really just any test that tells us something biological. It's a marker, a measure of something biological. The actual biomarker itself might be a blood test, it could be a brain scan, it might be an app on our phone. But it will tell us something that we want to know, something around a biological process. Now that might be the presence of a disease, and a test that tells us about the presence of a disease we might call a diagnostic test. Something that if you attended a memory clinic at the GP and were worried about an illness, a blood test or a test on an app might tell you about whether you do or don't have that diagnosis. There's other ways that we can manage a diagnosis to support that, and I think biomarkers work best when they're used together with other information to understand the history and the context of one's illness, for example, in an examination. But biomarkers could also tell us a lot about the stage of the illness. Am I early or late stage? Or to measure how an illness progresses. One of the features that all the dementias have is that they're progressive. So monitoring that progression, putting a number to it, will really help us as both managing doctors, but also in trials, trying to see if a new treatment slows down that progression. Something else that biomarkers I think are going to be very important for is around understanding our future. In other words, what can I measure today that tells me something important about what lies ahead, that we call it the prognosis. And if you remember me saying that earlier on, that people with mild memory problems, some of them will progress rapidly to dementia in a small number of years, and others will progress very slowly, if at all, and just have intermittent and annoying, but otherwise mild memory problems as life is pretty much as normal. Those two trajectories are very difficult to predict when you first see somebody, but there are reasons to believe that some biomarkers, particularly some blood tests, can try and distinguish those who are on two very different trajectories into the future. And biomarkers are certainly going to be critical for the success of clinical trials. You'll have heard and seen about biomarkers, often in terms of blood tests. This is, I think, from in March this year, April, when there was a big step forward in the types of biomarkers that can work for Alzheimer's disease. And I should just stress, this is really only in the realms of Alzheimer's disease detection so far. So it's in the headlines. Until very recently, these biomarkers were really the preserver of research in the laboratory. Only really this year, people talking about seriously about how they might be brought into everyday use in memory clinics or GP surgeries as part of a healthcare assessment for getting to the diagnosis. But actually, in many parts of the world, particularly in the States, where companies can go straight to consumers, there's really plans to put it into supermarkets, or at least to post it out to almost as a self-diagnosis kit. And so this going straight to the consumer is coming, but as I'll show in the next slides, it's fraught with difficulty. And I think we're on a very exciting time where we'll have a much more mature conversation with highly informed, self-engaged people, I won't even call them patients, they may not be ill yet, but members of the public are coming forward who've done tests or want to have access to tests. And then it's a question of how do we have a dialogue about what that means for them as individuals and for their health and their future. So just to illustrate this point, I'm going to show this one of the few data slides I'm going to show. This is using a chemical that's measured in blood. It's called phospho-tau217. This is a molecule called tau that's generated in the brain, and it has a chemical modification at the 217th position along the long stringy molecules. It's called p-tau217. And if we measure it in healthy controls, you have no amyloid and no tau. We have very low levels. If you've got some amyloid, it starts to go up. And if you have both amyloid and tau, you have quite high levels measured in blood. And what's extraordinary about this blood test is if we compare this to what's been the gold standard for 20 years, which is an amyloid brain scan, we see that this new phospho-tau is around 95% accurate against this amyloid PET or brain scan. And if you think that those brain scans cost many, many thousands of pounds each per scan, there's very few places in the UK where they can be done. To have this equivalent in a blood test really is a major breakthrough. But, you know, should we just sit back and think job done, we can relax and all go home? Unfortunately, it's not quite as straightforward. So there's some real challenges. These are research challenges that I think remain before it would be wise just to roll out these blood tests by post or in a supermarket. One of the big issues is we know enough about them to believe that the way they perform, how good they are as tests, is very different depending on your ethnicity. So the biochemistry of our bodies and our brains varies. We see this in some genetics. We see this in some of the existing biomarkers, that if you are of Southeast Asian or Chinese background, or if you're from African American or African backgrounds, by ethnicity or genetics, the blood biomarkers and the spinal fluid biomarkers just behave differently. We can't use one test with one sort of threshold to perform equally. The other problem is that they don't work as well for different dementias, or at least we'll have to say we need different biomarkers for different dementias. This 217 molecule I talked about works well in the context of Alzheimer's disease, but we don't have the equivalent for other diseases. One of the other problems we're starting to realize is that even a good biomarker like 217 has difficulty if you've got other diseases. So either you might have diabetes or kidney disease. This interferes with the tests, and these are extremely common illnesses. You know, 3 or 4 million people have diabetes or pre-diabetes in the UK. Kidney disease is very common. So we need to find ways to factor this in when we use the biomarkers test. And there's another sort of more nuanced question, which is to say, does it really help if we were to do such a blood test today, when you first come into clinic, if you came in today, can I look you in the eye and say, actually, this will be of help? In other words, when we meet in 2 years' time, you'll be healthier, you'll feel well, your mental state, your quality of life will be better. Can I look my hospital manager in the eye and say, if we pay for these tests now, we will be saving money? Will we be sparing unnecessary brain scans, for example? Will we be able to target tests and treatments at people who need it and save others from having unnecessary tests? So does it really help? And that, the answer is we're not quite sure. These are research questions that still need to be resolved. And I want to touch on an aspect of blood biomarkers which we just need to be cautious of. It's not to temper the enthusiasm too much, but it speaks to this graph. So this is looking at a large number of people, many, many thousands of people over the normal population. In the blue line here down at the bottom is people who have normal cognition, who are healthy. And it's saying, as you move forward over the lifespan, 20, 40, 60, 80, what proportion of people are positive for this amyloid? So they have some degree of biological activity of Alzheimer's disease, but no symptoms. They are well, normal cognition. And we've even taken out those who've got some of the high risk genes that might tip the balance. So these are healthy people, low genetic risk, normal cognition. And if you're a normal, healthy 80-year-old, around 30% risk that you're going to be positive for amyloid. Now, this is not causing you any illness, you have no symptoms. But think of the situation Well, you maybe may have some back pain, and either the back pain means you're not sleeping properly, you might be on some medication. So by virtue of pain, poor sleep and medication, your memory and concentration are not as good as it should be. And you come along for an assessment. And if one were to over-enthusiastically do a blood test that picks up this amyloid positivity, in a third of such people, we might say, you've got memory problems and you've got a positive biomarker. Your memory problems are caused by Alzheimer's disease. That's a risk. And that would be an injustice in the situation I just put to you, where it might be something much more treatable, much more benign around pain, medication, poor sleep that's causing the memory problems. So biomarkers need to be thought of quite carefully in that clinical context and not assumed to be a panacea that can bypass normal diagnosis. So to try and get through all those, I'm feeling rather negative at this point. I shouldn't be. I want to be much more positive. These are research questions. These are all surmountable issues. And the blood-based biomarker challenge that began this year has been funded by the charity, the Alzheimer's Research UK, Alzheimer's Society, the Postcode Lottery, and the NIHR, the NHS's research arm. They've co-funded a major national study, which is going to be called Readouts, which will look very closely at 3,000 people across the country, not just people who, what I might call typical volunteers who are who come forward for studies, but trying to make sure that the people coming into the study truly represent people of all backgrounds, all types of dementia embedded in healthcare memory services, whether they've got other illnesses, that diabetes and kidney failure, whatever their ethnic background, whatever their other health issues. So we can understand how these blood-based biomarkers perform for real. And there's a discovery science phase to this study, and that also builds in knowledge about quality of life. Part of this study is to say, at the 2 or 3 years into your journey with your symptoms, does knowing those blood biomarkers actually help you along the way? Does it improve your quality of life as opposed to causing more anxiety? Does it spare you from unnecessary tests, or does it trigger unnecessary investigations? These are empirical issues. And it's a very exciting time to be part of this, catching up with the science of the biomarkers, catching up with their impact on real-world health and quality of life. There's another study that's ongoing in the UK, and the UK should be really proud of leading the way in this type of research, which is to say, well, with many different biomarkers, we can measure things in the blood I've talked about, digital technologies, those wearables and our Fitbits and smartwatches. What about brain scans of different sorts, special eye tests? What about memory tests, the lumbar puncture for spinal fluid, and looking at the brain waves? There's many different ways we can study brain health and the health of somebody with memory problems. But and if you go to any different researcher, if you go to a blood test developer, they'll say my blood test is fantastic. If you go to someone whose research is in MRI brain scans, they'll say my brain scans are fantastic. If you go to someone who's developing digital technologies, they'll tell you that the digital technologies are fantastic. So the deeper frequent phenotyping study is unique in really doing a head-to-head comparison with the volunteers in the study. We do everything, and we're going to really do a head-to-head comparison to say, what is the answer to this question? Really, how do we know if a drug is working? What is the best test or combination of tests that can detect the change as people come into early stages of dementia like Alzheimer's disease? And how can we switch that off? How can we know in a fast and cost-effective way switch off this disease, preferably to do so before symptoms are really intrusive? So the deep and frequent phenotyping study is this really remarkable sort of coordinated UK-wide study to be able to address this very key question. And it involves a lot of academics, a lot of healthcare sites and then memory clinics, but it also has a lot of industry partners. And I think that one of the things that makes me much more optimistic now, more than 10 years ago, is a change in the way that academic and industry partners are working together. It's a much smarter, more collaborative approach, much more thought about who and when to treat. It's not just about which drug or which vaccine approach we might take. We want to be backing many different horses, but be smarter about identifying when they work, who they might work for. Can we get them to a stage where they're suitable to try very early in the illness, even to the point of preventing symptoms? So the research agenda has moved unrecognisably in a very, very short space of time. And I think we should all be much, much more optimistic now about substantial progress in the next few years. So just to sort of pull together what's been saying, I highlighted that dementia unfolds over our lifespan. And with that comes many opportunities to stop it, to intervene and prevent, many different strategies for treating it. And indeed, there are many strategies being tested at the moment, around 150 trials for Alzheimer's disease ongoing. We shouldn't forget there are many different ways to prevent it, though, some of which are in policymakers' hands, some of which are related to our personal choices. And some of those personal choices would involve how we feel about tests, new range of biomarker tests, to try and pick up the biology of what's happening in our bodies, and does it relate to our symptoms? Does it open up treatment possibilities? So blood-based biomarkers are coming in very quickly. With all those together, I think we can look to being much, much more proactive, much more active and proactive in anticipating and treating and preventing dementia. Just my last slide will highlight perhaps what you can do if you're listening and you're saying, what can I do? Well, the first thing I'd say is look after your brain, look after your brain health. The things that we can all do to help that: not smoking, keeping alcohol down, exercising well, keeping up with our friends and colleagues, and being socially active. All of those are good for brain health. If you're well, if you're lucky enough to be healthy, please support your NHS and don't use opportunities to support and argue for what NHS services need. NHS is a remarkable institution. We're very aware of some of the stresses and strains it's under over the last 3 or 4 years, but fundamentally it's an amazing force for change and good care. And if you're not well, if you're worried about health, then again, come forward through your GP into memory services to have these things looked at. And if you want to take part in research yourself, whether you've got memory problems, or perhaps for most people on this call, whether you're well, you can do so. And an easy point of contact to broker, to connect between you and researchers is through Join Dementia Research. And they can help connect you with research studies that are going to be of interest and within reach of you. So those are some thoughts of what we can all do now. Thank you for listening, and I'm very happy to take questions.
Thank you very much, James. Yeah, fascinating, and I learned a lot from your talk. Thank you very much for that. It's very clear your optimism for the future came across in your talk. One of the first questions that we've been asked is, how optimistic are you? And the question is, what's the estimate for timeline on this progress that you've been describing?
Yeah, so there's going to be things happening really quite quickly. So I think we can see over this next 6 or 12 months progress around these new drugs for Alzheimer's, whether they get not just licensed, but perhaps start to be embedded with permission to use in NHS services. That could happen in a small number of months. The availability for blood tests not being straight to consumers in the supermarkets, but being rolled out through memory services. I think we can look to see this over the next 12 to 24 months to enhance or enrich a memory assessment services, giving added value at very low costs. I mean, cost to participants, it's easy to give a blood test. It's much simpler than having a brain scan or lumbar puncture. So we can expect this to be unfolded over a short time scale. In terms of the sort of radical new treatments, I think these are things which will probably come soonest in some of those rarer dementias. So most dementias are not caused by a single gene. There are examples where they can come from a single gene mutation, and there is extraordinary progress now in highly targeted gene neutralizing treatments. There was last year recognition for motor neuron disease, ALS. Motor neuron disease has now got permission for a treatment that in a particular mutation targets and neutralizes the faulty gene. So we now have an example of a gene-based treatment in another neurodegenerative disease. Not dementia yet, but motor neuron disease is not far from dementia in its biology. So this is on the cards. I spent last week at a Frontotemporal dementia meeting where there are 7 different trials ongoing of effectively, I'd call it gene neutralizing treatments that have extraordinary properties in their preclinical workup. We don't yet know if they work for people with the disease, but it looks promising. So I think we'll see this in over 5 years. Alzheimer's is the big one, and I think it'll be around 5 years before we start to see multiple breakthroughs, and not just the 2 drugs we have at the moment sort of hovering, but multiple ones breaking through. And then we're into a whole new era. If we think about successful treatment of diabetes, most people on 2 or 3 different drugs. Successful treatment of HIV, most people on 2 or 3 drugs in combination. The same for cancer treatments. Normal cancer treatments, chemotherapy, it's 2 or 3 or 4 drugs combined. And it's this smart combination that prevents the illness breaking through any one drug and really can be effective. And I think that's where the sort of the mood of the field is going, is towards smarter combinations, but we're starting with one at a time.
You mentioned the parallels with cancer treatment there, and also mentioned that there's 6,500 trials for cancer treatments compared to 150 in Alzheimer's. Why is that? Is that a reflection on the research that's been done, the money that's being spent, or is Alzheimer's, or sorry, not Alzheimer's, dementia a more intractable problem than cancer?
My view is there's nothing intrinsic to dementia that makes it intractable. It's different. Part of it is as a numbers game. So the number of pounds per patient that's spent in cancer is an order of magnitude higher than it is for dementia. So there's just been a major investment in cancer treatments, really more than tenfold in terms of in cash terms, and that's led to progress being faster. There are some biological issues that might have given it an edge, but really I think it's around breaking through stigma. The cancer world broke through the stigma in the 70s and 80s. Back then, you wouldn't even tell people often they had cancer. It was unmentionable. The C word was unmentionable. We had to get through that phase to open up the discussion with people with cancer as participants in research and their families to move forward openly. And then the progress began. Dementia still has a lot of stigma. It's getting less. People, high profile people coming forward, whether that's, a few years back, like Ronald Reagan, or people more recently, like, the Bruce Willis effect, Bruce Willis and his family coming public around his form of dementia, people coming forward and talking about it openly, I think it really helps things move forward, getting rid of stigma. Actually, that's what I should have just said right at the beginning, and I realized I didn't, which is dementia is not normal aging. It's commoner as you get older. As cancer gets more common, we get older. Heart disease is common as we get older. Diabetes is common as we get older. But for some reason, we collectively all see those as diseases. We've allowed ourselves to think dementia is not a disease, it's normal aging. It is not, it's a disease. And we should treat it like a disease in research and clinically.
Excellent, thank you. Kathleen has asked the question, AI and machine learning are obviously being touted as the answer to all of our woes. So do you think that the use of AI could help accelerate some of the treatment and prevention processes that you've been talking about?
Yeah, definitely got a role to play, and we almost don't even notice AI now. It's all rolled out on our smartphones, invisibly in the background, and so on. AI is here to stay. It's already part of life. But it's rather like saying, will a computer help our research? The answer is yes, but in conjunction with people thinking, applying it in the right direction, using these tools. AI is a tool to be used, and it's very, very useful for handling complicated data. So rather than, in my talk, I highlighted one biochemical, the so-called phosphatide 217. Well, of course, actually, there's no reason why we can't measure 1,000 chemicals and bring that knowledge all together with AI. It's difficult to do one at a time, but AI tools are brilliant at taking complex data and squishing it together in a meaningful way. And that's what machine learning does, trying to see the patterns and extract those signals, those indicators. So, and we do this a lot now with complicated data. You can read a lot more from a brain scan with AI-based tools rather than just the old-fashioned sort of holding it up to the light. The reason I hesitate is to say I don't think AI should ever replace actually having a conversation with someone who's thinking and listening. What is this illness like for the person in front of me? How is it part of your life? it's not that there's one magic test or one magic brain scan or one magic cognitive test. It's always in conjunction with that consideration for the individual in front of you. But as a set of tools, AI, yep, they're here to, they're in use a lot already, and they're here to stay. They can also help make some predictions over molecules. So some of the colleagues who've actually, you have a gene, and you know that the impact of that gene has on the chemistry, let's say, of the tau molecule, and it gives it a particular shape. You can use AI to try and predict which set of chemicals will latch onto and bind, and perhaps be therapeutically targeting that. So for screening drugs, it's going to be extremely important, but as part of the process.
Thank you. I have a question here about, you mentioned that the risk for 75-year-olds now for developing dementia is significantly lower than it was in the early 90s. Why is that risk lower?
So I think a lot of that is steps that were taken to help heart disease are good for the brain too. Things that are good for the heart are good for the brain. So if you go back to the 80s and 90s, raising awareness and treatments around blood pressure and cholesterol and smoking, designed around heart disease, have had really profound impact on brain health in positively. So I think a lot of it is that. There may be other factors. I don't quite, I don't know, but I think the heart health and brain health connection is the main driver. Clearly, our genes have not changed. The genetic makeup hasn't changed in 25 years. Aspects of pollution come and go, but they're not radically different. I think most of it's around heart disease prevention and its benefit. What that tells us is you can change the risk of dementia by policymakers and personal lifestyle decisions.
Well, it certainly is hailing from the west coast of Scotland. I'd agree that heart health has certainly improved recently. Susan would like to ask a question about the potential of saliva as a test for biomarkers, and she's written here to Hebrew University. I don't know if there's something coming out from there.
No, it's a fantastic question. So as we, a short answer is yes. There are some of the molecules that are driving the dementias that can come out of the brain into spinal fluid in very high concentrations. They can come into the blood at lower concentrations. Some even eke their way into saliva. And the saliva is easy to get. Okay, it's almost infinitely available. So some of the tests, actually for Parkinson's disease, it's called the RT Quick test, which it's an ultra-sensitive test of the molecule that can trigger this slow cascade of alpha-synuclein. You can pick that up in saliva. Actually, ironically, it's easier in saliva than blood. You get a lot of background sort of fluorescence problems and background contamination that makes it quite tricky in the blood. And saliva can actually have the advantage for some molecular biomarkers. So yes, there's a lot of interest in saliva. The concentrations have been very low, so it's been a technical challenge to measure it at what it was now for the other biomarkers. We're into attomolar concentrations. So they're now exquisitely sensitive, and that's opening up saliva-based tests. And I think we'll see those coming through.
Thank you. Quick reminder to type in your questions to the Q&A. We're coming to the end of our time. We've got time for a few more yet, though. The age range that drugs are being aimed at, I think that you showed a graph of the stages of the disease. I can't recall if that showed age ranges, but of those 150, where in that age range are they mainly aimed at?
Yeah, so almost all of them at the moment are being tested in people who have symptoms. It might be mild symptoms, we call it mild cognitive impairment. It might be early dementia. They're almost all at that stage, but there's a very explicit agenda that where a drug works to block the illness and alter the course of the illness when someone's got mild symptoms, the next research stage is to take it to people who are pre-symptomatic. How vigorously you do that, how confidently you do that, depends on how demanding a drug it is. If a drug is as simple and as straightforward as we've come to think of it, like a baby aspirin a day, yeah, one can bring it forward quite comfortably into early life. You know, people's 20s, 30s, 40s, people take tablets of blood pressure, cholesterol, and aspirin, whatever. But some of the drugs are more complicated. They might need infusion. Okay, some of them need to be delivered by a neurosurgical procedure. So suddenly you think, oh, hang on, that's a bit more of a big deal. I'll be much more cautious about that. So there is consideration about how we would bring them earlier in life. And then some of the biomarkers we're looking at are trying to make a best guess, not so much saying, will I eventually get a dementia, but is it coming up in the next 5 years? So am I proximate? Am I getting close? Because one's risk appetite changes if it's coming up close. There might be treatments I would be willing to take to prevent something in 5 years, but I wouldn't be willing to take if I was just a healthy 20-year-old, you know, with a 40-year treatment schedule ahead of me. So trying to get this proximity right is a big part of the research agenda, with a view to prevention at the right stage.
I think that relates to another question that's coming here. So how many drugs will be prevention rather than cure?
I think, yeah, I think eventually most drugs will be looking to reduce the risk. And if you reduce the risk enough, we call that prevention.
Okay.
That's clearly the way it's you know, we want to be going and need to be going. And if I can prevent the disease long enough, I don't have to get it out of my body completely. I just need to stop it showing up as symptoms. If I can slow it enough so that it doesn't show up till I'm 120, well, I'd say job done. You know, if I can get you through to the end of whatever else, you know, cause our life to an end eventually, then that's the job done. What we want to do is to spare the unpleasantness, the indignity, the distress that 10 years of dementia can bring to people, and the wreckage that could cause in families in distress. So we you know, something will bring our life to the end eventually, but it doesn't have to be this long and awful illness of dementia.
Thank you. Hannah would like to ask about a very pertinent question about diagnosing dementia in your relatives. So how could family members identify the distinction between normal age-related effects and impairment and dementia? And how would you persuade relatives to go along to a memory clinic or to seek advice? Are there any particular signs that we should be monitoring for? Asks Hannah.
Yeah, I think there'll be many people on the call up and down the country, you know, responding to this and recognizing this situation. First thing to say is, not everything that's a memory symptom is due to dementia. I'm sure most people on the call will have the experience of going upstairs and forgetting while you're there. You pop to the kitchen or the fridge, you open the door and you forget what it was you're looking for. These are normal memory lapses. These are not the types of things that go with dementia or the signs of an early sort of pre-dementia. But other things, forgetting things a bit more significant, aspects of getting lost, losing things or getting lost, forgetting distinctive episodes, something you talked about, somewhere you went. These are things that might be more relevant. If they're starting to happen, I would say be open about it, talk about it openly. There are many things that can cause these symptoms that are not dementia. Fatigue, anxiety, depression, many medication side effects can all affect the clarity of thinking, and it'd be good to get those things dealt with. Hearing loss can be a major factor, very treatable. So if you're starting to get concerns, come forward with a very positive attitude that there's things that could be done to look into what I might call benign causes. Even if it turns out to be something like mild cognitive impairment or forerunner to dementia, these illnesses intrinsically change slowly. So there's time to get to grips with it, time to work out what it is that we're dealing with. And I would always say, better the devil you know. If you know what you're dealing with, you can be much more in charge of it and be in control of the illness and how it unfolds during the years ahead, and be very positive about the value of being in charge of the illness, not the other way around. It is a sensitive issue for many families. If you're the child of a parent and you're wondering, how do I persuade them to come forward, I'd say don't get so heads up that relationship stuff, because there's a long-term game to play here and there's time, but you can be gently supportive and encouraging to come forward, for positive reasons in it.
Excellent, very, very good advice. Thank you, James. And our final question, we've got a few minutes left. So what type of dementia is most common out of those that you highlighted?
Yeah, that's an easy one. So the most common one is Alzheimer's disease. About 6 out of 10 people with dementia is caused by Alzheimer's disease. So much so that for many people, the word is almost used interchangeably. Alzheimer's and dementia, they're seen almost as one thing, but that's the main one.
Thank you very much. Thank you very much to everyone in the audience that asked the question as well. I would just like to thank you again for a fascinating talk, and one which I think we can all agree does give us cause for being optimistic about the future of dementia research. So the final thing that I have to say is that, as I said at the beginning, this is the first of a series of 3 talks looking at dementia. So a couple of dates for everybody's diaries. On Wednesday, the 23rd of October, we're going to be hearing from Dr. Susan Koolhaas, who is Executive Director of Research and Partnerships at Alzheimer's Research UK, and she is going to be talking to us about the challenges and opportunities in developing new treatments for dementia. And then Wednesday, the 20th of November, we're going to be hearing from Professor Craig Ritchie. Craig is founder and CEO of Scottish Brain Sciences and is an honorary professor of psychiatry and aging at the University of Edinburgh. He is going to be talking about the brain health movement in the UK and why he feels that this is a life sciences priority. So I hope very much that you can join us for these other talks. Also, it would be remiss of me not to mention that SCI membership is available to everybody. It comes with a host of benefits, including access to a number of science conferences and talks and opportunities to network and talk with scientists. So visit our website to get some more information about that. That's at soci.org, that's soci.org. So thank you very much to the SCI team in the background, Nilukshi and Zoe, that helped run this session very smoothly. And thank you again to our speaker, James Rowe, for a very interesting talk and one which has been very enjoyable. Thank you, James.
Thank you for joining me. Thank you.
Thank you, everybody.